Silence. Okay, Assalamu alaikum everyone. I am Dr. Salma Abbas. I'm an infectious diseases consultant at Shaukat Khanum Hospital, Lahore, and I'm the infection control chair for Shaukat Khanum Hospital, Peshawar. This is the first of a series of webinars that we will be conducting, and this is on COVID-19. Our first speaker today is Dr. Mariam Hassan. She's our clinical research administrator, and the title of her presentation is Learning While Doing Research in the Times of Corona.
Assalamu alaikum. What I'm going to do in the next 10 to 15 minutes is to set the stage for the rest of the presenters today, who will be presenting various aspects of prevention, detection, and management of COVID-19. The title of my presentation is Learning and Doing in a Pandemic, because during a public health emergency, the reflex is to act. But it's very important that we also learn during that process of acting. This is going to be a brief snapshot of how research operates during a public health emergency. The aim is not to update you on specific research projects. This is something that my colleagues would cover anyway, but just to highlight the uniqueness of outbreak research and to also give you a gist of the challenges that we come across. So COVID-19 has landed us in an unprecedented situation, and this extract from a New York Times article aptly summarizes the situation. And it says that while countries have locked their borders, scientists have been shattering theirs, creating a global collaboration unlike any in history. And never before have so many people focused simultaneously on a single topic with such urgency that nearly all other research has ground to a halt. So this very aptly summarizes the situation that we are in currently. So in the next 10 to 12 minutes, I would be covering what happens in the scientific community when there is an infectious disease outbreak, the clinical implications of outbreak research before, during, and after an epidemic, and the challenges to conducting those research, and I'll end with some practical aspects related to research operations. We are all familiar with the basics of epidemiology, but just to quickly summarize this for everyone. So endemic is the farthest end of the spectrum when you have something that is prevalent, and pandemic is where we are right now, where you have an epidemic of a global proportion, which is what COVID-19 is. So I'm using the word outbreak throughout this presentation as an alternative to the pandemic of COVID-19, but outbreaks are generally geographically limited. So there are various research methodologies that are used during an outbreak, ranging from the basic epidemiology to the highest form of RCTs, which is clinical research, and they all serve their own purposes. So epidemiological research usually helps us in detection of an outbreak and its surveillance, and basic science research would form the earliest answers into the causality of that particular virus, including vector transmission. And then clinical research is what happens at the peak of an epidemic like COVID-19, where you want answers to prevention, diagnostics, treatment, and various public health measures that are being undertaken. My presentation is going to be focused on the clinical research aspect of things, and more specifically, we'll be discussing clinical trials because the process of learning while managing an epidemic, the main toolkit of that learning process is a randomized control trial. So we are all familiar with the evidence hierarchy, where an expert opinion forms the base of that pyramid. And case reports and case studies are usually considered the lowest form of evidence, and systematic reviews and meta-analyses of RCTs are considered the highest form of evidence with the lowest risk of bias. A similar model is usually followed for epidemic research also, but in epidemic research, we are often simultaneously seeing similar research modalities coming across to the scientific community at the same time. And while it does take us some time to evolve from case reports to trials, and case reports and case series have their own significance in detection of an epidemic and giving the earliest possible inclination of possible effects of, for example, different treatment modalities. It is clinical trials, which is the mainstay of evidence for epidemic research as well. The problem being that in an outbreak situation, we don't have the luxury of time like usual research endeavors, where you do have some time to come to a conclusion. So this is something that needs to be kept in mind. So before we move on to how epidemics change research, we need to understand what usually drives the research portfolio. So research is driven by researchers and those who are funding research. And those who fund research usually choose to fund those things that have the highest disease burden. So this is a snapshot of US funding based on the disability adjusted life years, which is a scale for the level of disability that is caused by a particular disease. And we can see that cancer usually takes the top position. It's the same if you look at global disability adjusted life years as well. So we see a similar trajectory for outbreak research as well. So when the disease burden increases, the output of research also increases because, and we have seen this in Zika outbreak, we have seen this even in largely endemic situations such as influenza, whenever, because when we saw the outbreak of H1N1, which is a novel infection in the background of influenza infection, we still saw an exponential increase in the research output, which was sustained for the next couple of years. We have seen similar trajectory for research output in the coronaviruses family as well. Another very important aspect is also the change in the focus of research over time. So in the immediately prior to the SARS outbreak in 2002, you see a word cloud which highlights the main research terms that were visible across the literature related to SARS, and you can see that the focus was mostly on etiology. During the outbreak, the focus is mostly on detection and diagnosis and symptomatology and treatments. And once the peak of that outbreak is over, there is greater focus on understanding the control of that particular disease. We have seen similar outbursts of research activity for COVID-19. So a review of the Scopus, which is an Elsevier database, you see that from 6 publications towards end of 2019, we have close to 7,000 publications, and we have barely completed the first quarter of 2020. The main focus of our research activity has been largely clinical research, which means that we are interested in finding ways of managing that disease. If we look at the geographical distribution of that research, most of that research is confined to countries most affected by COVID-19. And the funding across the world is also mostly by government-funded bodies and some by pharmaceutical sponsors. I will next move on to the second and the concluding part of my presentation, which is about how research operates and what are the challenges to outbreak research. So this figure shows the health research profile indicators for a country. It goes without saying that you need to prioritize research, you need to have resources, way to produce those resources such as research centers, package that information via research networks and publications, and to have an impact of that research on your policy making. But all of this operates within a context of politics, economy, history, culture, and law. And all of this has an impact on the research process. I would like you to keep these 2 slides in your mind because we will review this in the context of LMICs as well as we move across. So we saw this flow of emerging evidence during an outbreak research, and I did declare earlier that my focus is going to be on RCTs, which form the main focus of our learning tool during epidemic research. So a look at the clinicaltrials.gov website, which is one of the world's largest registries for clinical trials, shows that currently there are more than 1,400 clinical trials across the globe which are registered for research into COVID-19. A review of clinical trial registries towards end of March 2020, and this is now archaic data, I realize that, because we are well into a month beyond this particular review, but it gives you an idea of where we are. We already had more than 300 clinical trials into COVID-19, but the distribution of these clinical trials was centered in countries either most affected by COVID-19 or high-income countries planning most of the forthcoming trials. And very few trials were being planned in low- and middle-income countries. I will take you back to that health research profile indicator. The reason why we don't have as much planned research originating from LMICs is because our health research profile indicators lag behind in nearly all critical aspects, and our context is not very helpful as well. And this has has contributed to the 1090 gap in research, which is that less than 10% of the global funding for research is spent on preventable mortality of more than 90% of the conditions that LMICs face. And within this context of a poor health research profile and a 1090 gap, we also have the added challenge of challenges associated with outbreak research. So during an epidemic, to just do things, but it's also very important that we learn as we do. As I have emphasized earlier as well, the chief tool in the learning toolkit is an RCT, a randomized control trial. But the issue is that in an epidemic situation, randomization becomes even more profoundly uncomfortable for a clinician whose instinct is to treat patients and not to toss a coin and delegate a patient to a placebo arm. Also, the deployment or the conduct aspect of RCTs is usually tedious as well. The approvals process as well as the running of an RCT becomes problematic. And those who fund or conduct RCTs often cannot present a unified plan because the evidence is emerging and the risk-benefit assessments become extremely. These particular challenges is to balance the need to rigorously test a new medicine for safety and effectiveness with the moral imperative to get patients a treatment that works as quickly as possible. If we have time towards the end, I would, and I know that we probably don't, I would take you through the controversial decision by NIH to recently stop the ACTS-1 study, which alluded to the effectiveness of remdesivir and led to use of remdesivir authorization by FDA. There are solutions to this as well. And with the solutions, I come to the end of my presentation. The solutions are actually needed starting from the planning stage. We need adaptive trial designs that are responding to upcoming evidence. There's need for communication to develop consensus around equipoise, which is a very problematic area during an epidemic and which is the basis of randomization. And to understand that we only can come to causal inference if there is collaboration and if we undertake large-scale platform trials that follow an adaptive study design, and I'll be happy to take details of adaptive study designs during our question and answer sessions. In the approvals process, there's a need to have a rapid response, but there is a need to have ethics preparedness as well, so that human research participants' rights, safety, and well-being is also protected. It's also very important to ensure community engagement in study conduct using simplified procedures. And developing consensus on clinically valid endpoints that really benefit patients is really important. And finally, and most importantly, a timely dissemination that also factors in some time for reflection over available evidence is extremely important as well. With this, I come to the end of my presentation. Thank you.
Thank you, Dr. Mariam. That was a great insight into research in the times of Corona. We will take questions from Dr. Mariam at the end of the session. Our next speaker is Dr. An Raza. He's an infectious diseases consultant at Shaukat Khanum Lahore and also the chair of infection control at Shaukat Khanum Lahore. The title of his presentation is COVID-19, Prevention and Control of Infection.
Thank you, Dr. Salma. Assalamu alaikum and good afternoon. I'm Dr. An Raza and thanks for the introduction, Dr. Salma. I'm going to discuss regarding the prevention of COVID-19. This is the outline of today's presentation. So briefly, I will discuss the overview of virus spread. We all know the symptoms of virus of the COVID-19 by now, and that it can cause fever, sore throat, and etc. We all know about the transmission, because before talking about the prevention, we should know about the transmission of this infection. So this infection, it is transmitted by respiratory droplets from person to person. When an infected person coughs or sneezes, it produces droplets, and they can land on a person's mouth or nose who is uninfected, and he can be infected then. The other mode of transmission is contact. When we touch a contaminated surface or object, our hands, they get contaminated, and then when we touch our hands to our face or eyes, then the virus can be transmitted. So the most common surfaces like door handles and gadgets like computers and ATM machines, etc. So next I will discuss what are the modes of prevention. So generally for any disease, when we're talking about the disease prevention, there are two modes of prevention. First is vaccine, and second is to avoid exposure. So regarding COVID-19, vaccine is not available currently. And we'll see how we can avoid exposure. So if we talk about vaccine, so since the start of this outbreak, there is a race of developing a vaccine throughout the world, and people are trying to produce some vaccine. So this is the share of vaccines being developed by various countries. You can see that the largest research is going on in large proportion of the research is going on in North America, followed by China and Europe, etc. So these are few trials which are currently ongoing, and they are mostly in their phase 1 and phase 2 trials, and no result is available as of yet. And still they are recruiting, and we don't know exactly when we'll have a vaccine for this disease. It may take another year or 18 months. So let's move on to prevention, other mode of prevention, which is to avoid exposure. So I just went through the newspapers, and so there was a news that UK started its first human trial of COVID-19 vaccine on 23rd. And even a Chinese pharmaceutical company, it also contacted Pakistani government to start clinical trials for COVID-19 vaccine, but we haven't heard anything so far. So how we can avoid exposure? First of all, for general public, if we talk about that this is a community infection and community-based transmission is ongoing in Pakistan as well. So first thing is that hand hygiene. So we all know by now that it is very important, and it is one of the best strategy to avoid this infection. So everybody should wash their hands with soap and water for at least 20 seconds, and alternatively, they can use hand sanitizer, which should contain at least 60% of alcohol. And then we should avoid touching our eyes, nose, and mouth with unwashed hands. And this is important, that especially when we are going outside, and then we should keep a hand sanitizer with us whenever we touch different surfaces. We should perform hand hygiene. And before entering the house, we should use hand sanitizer and wash our hands after entering the house. So these are the few recommendations by WHO, that we should wash our hands after coughing or sneezing, when caring for the sick patient, before, during, and after prepare food, before eating, after toilet use, when hands are visibly dirty, and so on. Second important thing is that whenever we cough or sneeze, we should cover it with either a tissue paper or with the bend of our elbow, as shown in the picture, and so that we do not spread the infection to others. And we should throw the used tissue in trash, and then wash hands or use hand sanitizer after coughing or sneezing. The next important thing, which is very crucial in these days when the lockdown has been eased now, and we see a lot of people going out and doing shopping. So that is social distancing. What do we mean by social distancing? That we should maintain at least a distance of 6 feet or 2 meters from one another. The first thing is that we should stay at home and avoid going outside, and especially places where like closed places and with a public gathering. But if it is inevitable, then we should maintain a distance of at least 6 feet from one another. Regarding face mask, so in the current scenario, I would suggest that everyone should wear a cloth face mask whenever they are going out in public, especially in a closed environment, like in the grocery shop or in the pharmacy, things like that. And the cloth face cover is meant to protect others, because if I am infected and I'm wearing a cloth face mask, then I will not transmit the droplets to other people who are healthy. But we should not use the face masks which are meant for healthcare workers, like N95 or surgical mask, because that will not provide us any protection. So it is basically for the protection of others. So there are several recommendations for the use of cloth mask now. CDC also recommends the same, especially in areas of significant community-based transmission like Lahore, Karachi, Peshawar. Similarly, there are other reports which were published in New England Journal of Medicine, which they suggested universal masking in hospitals and in community as well. And why are we suggesting this? Because we know that there are reports in which people had a COVID-19 test positive and they were asymptomatic. So to avoid that transmission of infection from asymptomatic carriers, this is the recommended. This universal masking is recommended now. So the next thing is cleaning and disinfection. So we should clean and disinfect frequently touched surfaces daily in our houses or offices, like tables, doorknobs, light switches, etc. And if the surfaces are dirty, then clean them with detergent or soap and water prior to disinfection. Simple household disinfectant is sufficient for this purpose. Well, regarding prevention for healthcare workers, we should all follow standard precautions, which include obviously hand washing, using gloves when we are dealing with body fluids or blood, disposing of sharps properly, and disposing of clinical wastes in designated bins, and of obviously covering cough. So these are the standard precautions which should be exercised by the healthcare workers as well as visitors and patients in the hospital. Then comes transmission-based precautions and the use of personal protective equipment. So the transmission-based precautions include contact precautions, droplet precautions, and airborne precautions. So for COVID-19, the recommendations are that we should, when you are going to see a patient with suspected or confirmed COVID-19, you should apply standard precautions, droplet precautions, that means wear a surgical mask, contact precaution, that means wear gloves and gown, and face shield or goggles. But if you're going to see a patient who is confirmed or suspected with COVID-19 with an aerosol generating procedure, like a patient who is on ventilator, who is going to have a tracheal intubation or tracheostomy, or CPR for that matter, then we should use standard precaution, airborne precaution. That means that all the healthcare workers should wear N95 masks, should wear gloves and gown, and face shield or goggles. So this is the PPE recommendations in our hospital, and I would suggest that every hospital in the country, they should prepare their own PPE recommendations based on in the light of these previous recommendations. In the end, I would emphasize that in the current scenario, we should be more vigilant while regarding the sequence of putting on personal protective equipment and removing the protective equipment, because most of the healthcare workers, when they are not removing the PPE in a proper sequence, they can get infected, and they should perform hand hygiene between each steps of removing gloves and face shield and then gowns. And in the end, they should remove a mask or respirator. So this is very important and crucial in current scenario. Thank you.
Thank you, Dr. Ron. I would like to request our viewers to please keep the questions coming. We will address them all at the end of the session. Okay, we'll be shuffling the order of presenters. Our next presenter is Dr. Romina Kazi. She's a consultant molecular biologist, and the title of her presentation is Challenges in Setting Up COVID-19 Testing Facility at Shaukat Khanum Hospital.
Hello everybody, Assalamu alaikum. Excuse me. So I'm Ramina Qazi, as she introduced me. I'm heading the molecular diagnostic lab here at Shaukat Khanum Hospital. And I'll be talking about challenges in setting up COVID-19 testing facility here. But before going into the discussing or sharing the challenges, I would like to mention here that our lab at Shaukat Khanum is not true representative of the labs in Pakistan, because we have a very well-equipped lab and we have all these equipment that is already present in the lab, like all these different multiple units of thermal cyclers that are used for manual assays and automation as well, where we just put the sample and get the results in 3 hours. So we are using all these different machines, manual as well as automation, for COVID-19 testing. As well as we have this machine, you can see this Cobos X480 Hamilton. This is used for pooling, and this we use in normal situation, we use for blood donors. But here we are using this for pooling, as I'll touch upon this later on. And we have this gene expert as well, and this will be using when the kits for COVID-19 will be available at the end of this month. So you can see that we have a very well-equipped lab. This is just few of the equipment that I've shown, which we are using for mostly COVID-19 testing, because we have a plethora of tests that we do not only for oncology, like hematological malignancies and solid tumors, but we also have multiple molecular diagnostic tests for infectious diseases like hepatitis, HIV, like bacterial infections, as well as for transplant and fish and cytogenetic lab. So the reason why I brought this cytogenetic lab is later on I'll touch upon this, that how this became very handy for the setting up the molecular diagnostic for COVID-19 testing. So the main problem in lower middle income countries is procurement. Because in the West, when you order something before 10 a.m., you get the reagents and kits by 4 p.m. on your bench, and you can start working with them. But in countries like ours, procurement is the main issue, because it takes more than 2 to 3 months. And when I learned first about SARS-CoV-2 at the end of December, early January, I started looking for the available material resources for testing this COVID-19. Excuse me. So I found, because on 10th of January, the genome of this COVID was released, and many of the companies as well as CDC, they published the primers. So we ordered those primers from CDC, as well as we ordered some kits from UK. And while we were waiting for the kits and the primers to arrive, we started planning, which is very important and main thing for establishing or developing any diagnostic lab. So what we did here for COVID was, because we have all these SOPs and stuff already in place for molecular test, but because this is what was a different infection and different test, therefore we had to convert a normal routine molecular diagnostic, one of the lab, into COVID testing lab. For that, we had to work on guidelines, for example, SOPs, the standard operation procedures, like what should we do with the samples, how to receive them, log them, and stuff like that. Extraction units, PCR, stuff like that was all included in those SOPs. Then we had to look into PPEs, that what PPEs, specific PPEs are required. And we were looking into like N95 goggles, face shields, gloves, disposable gowns, head covers, shoe covers, or hazmat suits. Similarly, we looked into if there are any specific guidelines for waste disposal, because these were COVID specific specimens, although we take every specimen that comes to the lab as infectious, but this was different. So we were looking into specific recommendation from CDC or WHO and our hospital infection control policies for waste disposal. And in addition to that, very important was biosafety for the biosafety training for the lab technologists. Similarly, we also looked into operations. For example, most importantly, we wanted to see what inventory do we have for running these tests. Then we were looking into staffing, then new equipment if it was required to be installed in the lab, etc. And most importantly, I was looking into the validations, because whenever we get kits for launching or testing, we validate them before we launch the test, and validations are very expensive and they need funding. So because of the very support from the hospital, we did validations for these kits. As we went along our way of testing, we found that there were inherent problems with some of the kits. Their sensitivity was different and stuff like that. So we had to really validate against the best kits that were available. Then we had to rapidly expand our lab, and expand means that we had to convert the routine molecular lab into COVID testing lab. Not only that, but we had to borrow a lab from basic science department, which is next door neighbor. We took one of their lab and converted that also into a COVID testing lab. And then we had to relocate all the equipment necessary to perform these testing. So the biosafety cabinets were not enough in that lab. So we had to move the cabinets from other labs from pathology department. Similarly, we also had to build capacity of human resources, because if we have all this equipment but we don't have resource, we couldn't perform the tests. So in addition to molecular lab technologists, we had to train technologists from other labs from pathology department, as well as we borrowed some research associates from basic science department, and we trained them all on all the benches from manual RNA extractions to PCR, and we had to give them these lectures on biosafety and all that, so that they were eligible to work in those COVID testing lab. So we trained about 20 people before we got the kits. So when we got the kits, we started working on them day and night. We had 3 shifts, and we increased our capacity of testing from 300 tests per day to 3,000 tests per day, and that includes both manual extractions, manual assays, as well as automation. So manual, we could do 1,100, but with automation, we started doing 300 tests per day. We could do. But with increased number of tests per day, the problem arose of the shortage of supply chain. So the main shortage was of swabs and viral transport medium, VTM. So here the cytogenetics lab that I mentioned early, it became handy, and we used the sterile reagents that they have. We used that CDC protocol, and we made our own VTM, the viral transport medium, and then we validated that medium against the vendor's medium. And when we had the same results in PCR, we shipped those viral transport medium to different collection centers. And in addition to that, well, it was easy. It is easy. It seems easy said than done. We naturally had a lot of hindrances and problems, but we overcame all with our commitment and teamwork. Then, in addition to that, we had to help the government, because there were these Zairines that they came back from Iran, and they were quarantined in 3 different camps in DG Khan, Multan, and Faisalabad. We got quite a lot of samples from them, and we had to perform them in very short time. So we had, with this human resource capacity and expanded labs, we could perform the testing for the government for free. In addition to that, we have set up a COVID assessment and triage camp at SKM. We still offer free testing in our camp as well. So with all these free testing in the COVID camp at SKM, and for the government and from the collection centers and across Pakistan, we were asked to increase our capacity, and that's where the pooling comes in. So we pooled samples, and there are different methods for pooling. So we used the automation, the one that I showed you in the picture already, and but we used manual pooling as well. And we increased our capacity of testing from 3,000 per day to about 20,000 per day with pooling. So the take-home message here is, if we plan and we have a strong teamwork and commitment, we can take any challenge that comes our way. Thank you.
Okay, so I will be giving the next presentation, and this is on COVID-19 treatment. So I will be covering the medical aspect of this, and then my colleague Dr. Rehan will be following this presentation. We'll be talking about the ICU management. So I have a disclaimer for my presentation. It's important to note that to date, there are no approved anti-infectives for treatment of COVID-19. There is no consensus on which drugs to use. The therapies that are currently prescribed are either done so in an off-label capacity or an investigational capacity. The existing evidence that we have from research studies is either consistent of small studies, case series, case reports. We do have some trials, but there are flaws in the designs. And the disappointing part is that we're 5 to 6 months into this. It was initially an outbreak and then became a pandemic, and we still do not have the amount of literature that we should have had, 6 months into it. To date, 978 trials have been registered on COVID-19 treatment on clinicaltrials.gov. So what treatments are currently being used? So it's literally the kitchen sink that has been thrown at these patients. There's hydroxychloroquine, there's chloroquine, there are natural remedies, there's ivermectin, there's plasma, there's tocilizumab, there's remdesivir, there's lopinavir, ritonavir, there's montelukast, there's arbidol, there's favipiravir, and other natural remedies, or standard of care, or nothing at all. So I will now go over the treatment modalities and medications that are available and are being used in Pakistan. So I will start with chloroquine and hydroxychloroquine. These are the drugs that have the most literature available on them. The mode of action and the rationale for use. So it raises the pH. So first of all, hydroxychloroquine is a safer alternative for chloroquine. These drugs raise the pH of endosomes and prevent viral entry into the cells. The key toxicities are QT prolongation and retinal toxicity. Retinal toxicity is generally seen with very high cumulative doses and happens over a long period of time, whereas QT prolongation can occur within a few days or a few doses. So going over the existing literature, so there have been some RCTs or randomized controlled trials that have been conducted to look at the utility of these drugs. The RCTs were generally biased and mostly looked at patients with either mild or moderate disease. The endpoints that they specified were either different from the protocol that they had initially sought to target, or they were missing information. Like key information that was required for the trial. In addition, there's been concomitant use of other drugs in these studies, such as arbidol, interferon, lopinavir, ritonavir. Again, there's been conflicting evidence from these RCTs, and some trials were terminated prematurely. There was recently a trial which compared high-dose chloroquine with low-dose chloroquine, and that had to be terminated because of the side effects and QTc prolongation. There's an observational study that came out this week, which again demonstrated that hydrochloroquine administration is not associated with a greatly lowered or an increased risk of composite endpoint of intubation or death compared to no drug. So basically, it was neither better than nor worse than no therapy at all. And again, there have been studies looking specifically at QTc prolongation. One of these studies reported about 10% with 10% of patients receiving hydroxychloroquine who develop QTc prolongation. Others have reported a higher percentage. So in the light of this evidence, what's our verdict? It's that it's best to use this drug in the setting of a clinical trial. Now moving on to a similar treatment strategy is combination of hydroxychloroquine or chloroquine with azithromycin. Again, So what's the rationale for using a combination therapy? Is possible synergy between these two drugs. The key toxicity. So both of these groups individually cause QTc prolongation, and with the combination, the risk is obviously multiplied. The data on this is mostly observational studies. There was a paper that came out last week that showed that compared with patients receiving no therapy at all, there were no significant differences in mortality for patients receiving hydroxychloroquine plus azithromycin or hydroxychloroquine alone or azithromycin alone. Similarly, they also saw that compared with patients who received no drug, cardiac arrest was significantly higher than in patients receiving hydroxychloroquine and azithromycin, but not with hydroxychloroquine alone or azithromycin alone. Again, the risk of QTc prolongation multiplies when you combine these two drugs. And the verdict is, again, to use it in the setting of a well-designed clinical trial. It's worth mentioning that we were also among the centers who were using hydroxychloroquine and chloroquine to treat our patients, but we have since removed these from our institutional protocol for COVID management. Then moving on to lopinavir ritonavir, it's a viral protease inhibitor, and the key toxicities are QT prolongation, hepatotoxicity, GI side effects. Looking at the existing literature, so there was a well-designed trial conducted to look at lopinavir ritonavir with about 199 patients enrolled, allocated 1:1 to lopinavir ritonavir versus supportive treatment only. Some critiques of this paper say that it was administered too late to patients over 13 days later once their diagnosis had been made. But basically, this showed no difference between the two groups in terms of mortality. There was no difference in viral decay, and but the failure in clinical improvement was lower in the lopinavir ritonavir group. So again, existing evidence does not support the use of lopinavir ritonavir. We do need further studies to elucidate the role of lopinavir ritonavir in treatment of COVID-19. Now moving on to tocilizumab, it's an IL-6 receptor inhibitor, and it has a possible role in cytokine release syndrome or cytokine storm, which is implicated in severely ill COVID-19 patients. The key toxicities are immunosuppression, hypersensitivity reactions, hepatotoxicity, cytopenias, hepatitis B and TB reactivation, and intestinal perforation. So obviously needs to be administered very judiciously. And this is an expensive drug too. So institutions should develop their protocols as to when to administer this and what doses to give, so on and so forth. So the existing evidence, so there were 2 small case series on this initially, both small sample sizes without control groups. The dosing in these studies was inconsistent and inconsistently combined with other inflammatory medications such as steroids. In one of these, there were 15 patients, 7 were critically ill, 6 were seriously ill, 2 were moderately ill, 3 were critically ill patients who died after receiving a single dose of tocilizumab, but overall 10 patients improved. This could be seen by the length of stay in the hospital and also downtrending CRP and IL-6. At our hospital, this is one drug that has shown some promise. We have so far used it on 4 patients with good clinical results. And the verdict on this is that, yes, it does seem promising, but again, what we have available as far as literature is concerned is a small case series, and we do need further studies to further elucidate the role of tocilizumab. Moving on to convalescent plasma. So the rationale for giving it is that it contains antibodies to SARS-CoV-2, and by giving this, we're trying to instill passive immunity in patients. The key toxicities are allergic reactions, and the existing evidence generally consists of small case series, again, small sample sizes, not adjusted for co-treatments, baseline characteristics, disease severity, and timing of plasma delivery. The important thing to note is that if this is considered as a therapy, it must be administered before the patient starts developing their own antibodies for this to be effective, so which would be around 7 to 10 days. In this study that I just mentioned, they looked at 8 mechanically ventilated patients. 50% were extubated at the time the study was published. Again, there was limited data on the time taken to extubate these patients. So again, this is not a novel concept. It has been used for centuries now, starting in the 18th century when it was first used. But we do need further studies to again elucidate its role in the treatment of COVID-19. And lastly, remdesivir. This is a drug that is not yet available in Pakistan, but we hope that it will be over the next 12 to 14 weeks. This is an RNA-dependent RNA polymerase inhibitor. The key toxicities are GI side effects and hepatotoxicity. Looking at the current evidence, so there was a case series that was published last month with 53 patients who received remdesivir with improvement in 63% of the patients, and there was 13% mortality. Again, the study did not have a comparison group. A randomized control trial was started in China, and it came out at the beginning of April. And they basically looked at remdesivir versus standard of care. Unfortunately, it had to be terminated prematurely because they were not able to enroll enough patients to continue this trial. Again, because of a good reason that China was able to control their outbreak. So it did show shorter duration to clinical improvement compared to standard of care, but again, since it was not a well-powered or appropriately powered trial, the results were not statistically significant. Again, this is a promising therapy and needs to be further evaluated in well-designed trials. Moving on to prophylaxis. So there's currently no role for prophylaxis as far as COVID-19 is concerned. The big reason being that we're not even sure if the medications that I went through are appropriate for treatment, let alone for prophylaxis. So once we have established what we can use to treat this disease, we can come up with or think about prophylaxis as the next step. So currently prophylaxis is not recommended. So what's the bottom line? The current evidence that we have available on treatment modalities for COVID-19 is hypothesis generating, but it's not conclusive. We do need further studies to further elucidate the role of all these agents in treating COVID-19. These drugs may be considered for use in patients with moderate or severe disease where no contraindications exist, and it's best to limit the use of these in the setting of well-designed clinical trials. Thank you. And I would like my concluded line to be, prevention is always better than cure. So as my colleague, Dr. Onraza earlier pointed out in his presentation, please be very vigilant with hand hygiene, practice good cough etiquette, and maintain social distancing. Thank you. Our next speaker is Dr. Rehan Akram. He's an ICU and EAR consultant, and he's the director of ICU at Shaukat Khanum, Lahore. The title of his presentation is ICU Management of COVID-19 Patients.
Assalamu alaikum, everyone. Assalamu alaikum, everyone. So I'm Rehan. So we'll try to go through the salient features that I want to talk about in management of ICU with regards to COVID. So we've got 10 minutes and I've got 30 slides, so about 20 seconds per slide. So I'll try to be fast. So just pace along with me, please. All right, so we're going to talk about 6 things. First is about thrombosis and VT in COVID. Then we'll talk about steroids, then NIV and prone positioning. And lastly, we'll go through sedation and ventilation. And a lot of patients are alone in a single room where there is no family visits, no computer or mobile, and they're pretty depressed and anxiety and how to deal with it. And lastly, we'll just talk a little bit about old agents and new users. So it's pretty prothrombotic. And we are seeing more and more articles coming about pulmonary embolisms, DVTs, strokes, and arterial thrombotic events. We'll just go through a few of them. This is the first one from Journal of Thrombosis and Heme from China that showed that treating with heparin had a reduced 28-day mortality. The critique on this article was that in China, usually they do not use thromboprophylaxis, where in most of the world and here in Pakistan, in most of intensive cases we do. But then there is this Netherlands study just published earlier in April, That shows that despite prophylaxis, there is 31% incidence of thrombotic complications in ICU patients. PE was seen as about 27% of patients, and 4% of patients also had arterial thrombotic events, which were significant events that led to intervention. Now, this is the French study, which is accepted proof being published at the moment. This is an excellent study to read. This shows PE in about 17% of patients, CRRT clotting in 96.6% of patients, ECMO circuit clotting in 8% of patients. And this study, which we now know, is that about 95% of patients had elevated D-dimers and fibrinogen. No patient actually developed true DIC. 87% of patients tested positive for lupus anticoagulant. And when you match these patients with non-COVID ARDS patients, that COVID patients, 17% had PE, whereas a non-COVID ARDS had about 2.1% of PE as a complication. So just emphasizes that how big and massive the problem is of clotting in these patients despite being on prophylactic anticoagulation. So in summary, this is not DIC. PD-APTT in most of the patients is normal. Platelets are usually raised. D-dimers are rising as the illness is going on. Fibrinogen is usually most commonly raised. And peripheral blood film is unremarkable. It doesn't show eaten up cells, MAHA, or microangiopathic-like pictures. Our approach, we do the D-dimers. Everyone goes on to prophylactic anticoagulation, but if the D-dimer is raised, they go on to therapeutic anticoagulation from the very start. If renal functions are normal, they go on to 1 milligram per kg of enoxaparin BD, and if renal functions are off, we go to heparin infusion. Steroids. So I know that a few units here in Pakistan are using it, some are not using it. This is just a very good slide that I picked up from a stage 1, stage 2, and stage 3. And probably we are getting the patients at about stage 2 to stage 3, and where probably there is role for steroids as well. This study is early corticosteroid treatment in coronavirus patients. So when you look at the study closely, early steroids were the patients who were given early steroids were less likely to deteriorate clinically. This study is also being cited as actually on the opposite side, because the viremia did increase in the early steroid group, but in the late steroid group, there was no increase in viremia, and there was less likely to deteriorate clinically. So if you look at the clinical picture, this is actually a positive study for steroid that they do not deteriorate. Next one is from CHEST 2006, which is your coronavirus COVID-1 stream. So it reduced mortality, it shortened ICU stays, it was not associated with any increase in secondary infections. This one was from the MERS, which is again from the same corona family virus. And among patients with non-severe disease, steroid use was generally non-beneficial. Among patients with more severe disease, steroid correlated with improved survival. Another one, which is just published, I think, last week, is that steroid therapy correlated with more rapid improvement in oxygenation and radiographic abnormalities. Patients treated with methylpred were weaned off earlier, 8 days versus 14 days. The last study just published last week as well, JAMA. And this essentially shows that in the severe disease, methylpred may prove beneficial who do have bilateral infiltrate and have ARDS. If you sum this up, there is no prospective RCTs, but steroid is usually administered to most of the sick, and it may cause benefit. None of the studies show that it actually causes harm. We, as an institute, we are giving steroids from the very get-go, and we do tail them off after about 5 to 7 days. Non-invasive ventilation. So when we started doing non-invasive, which is from the very start again, the main caveat was risk profiling for the doctors, nurses, and respiratory therapists and paramedical staff. Everyone was very anxious that would it increase their chance of getting the virus. So some studies with regards to that is that JAMA, 138 hospitalized patients, this is from the China, where we will just break the study up. 78% of the people that got actually infected, healthcare workers, were working on the general ward. About 18% were working in the ED, and only 2, which is 5% of the total population, was working in ICU. So the risk of transmission in healthcare workers is low, except where the healthcare worker is not vigilant and not having a proper PPE, and they're working in an area where there is no PPE. With appropriate PPE, the risk was much less. Another from Lancet 2003, from the first COVID-1 infection, and this showed that actually none of the personnel who utilized all 4 measures, which was gloves, masks, gowns, and hand wash, were infected with SARS. And contrastingly, all of the healthcare workers, including the ICU ones with nosocomial infection, had failed to implement at least one of the PPE methods. What we have done here is that we have created negative pressure rooms and whole of the unit. And negative pressure usually would be about more than 10 air exchanges per hour. We did that by putting extraction fans onto the windows, which leads outside. And we do proper PPE with N95 masks. We do give BiPAP. We titrate the PEEP and pressure support according to their ideal body weight. We use inline filters, viral filters on the exhalation ports as well. And that's how we reduce the exposure to our RT, our nurse, and our doctors. And these viral filters are widely available in Pakistan and are actually pretty cheap. Just as a summary, there is that WHO Surviving Sepsis campaign and NHS all are a yes for NIV. With regards to high flow, there is one study that shows that if you put a mask on top of the high flow, actually the aerosolization becomes much less. While they are on BiPAP, it allows us to do active proning as well. And proning, to our experience here, is just massively helpful. It does require a lot of encouragement to the patient, and they do require constant reminder, because these patients are happy hypoxic. They will be sitting at 85, chatting away without any problem. So you do have to remind them that they actually do have a disease where they will deteriorate very rapidly, where they wouldn't realize it, that they are actually deteriorating. So make it a habit that whenever you go in, talk to them and make them do at least visibly in front of you prone positioning for at least 12 to 16 hours a day. And in that way, you will see rapid improvements. And we have seen from 12 to 15 liters coming down to 6 to 8 liters, and they stayed there for the rest of the stay and got discharged. Now, sedation and ventilation. Now, aim is to keep them breathing. We are not heavily sedating our patients unless they absolutely need it. You avoid paralysis if you can. Use modes where patient is allowed to breathe by themselves, hence pressure support is incorporated. The mode that we are using here is nothing fancy like APRV. We are just using simple SIMV, either volume control or pressure control with pressure support. We reduce the sedation, and as soon as they are able to breathe by themselves, we let them breathe by themselves. We do take care of the volume so that we can prevent volume trauma or pressure trauma and reduce pressure support as the lung compliance is improving. We only had to do paralysis on one patient, and that's all. We rapidly reduce sedation once FiO2 is better and extubate. For sedation, we are using opioids and dexmedetomidine as the first line. With regards to opioids, we do have a shortage of fentanyl and morphine, and I don't think so that situation is much different in the rest of Pakistan. So we are using nalbuphine as a substitute. Nalbuphine, usually you would require about 5 to 10 milligrams an hour, which will be sort of equivalent to about 100 mics. About 10 milligrams would be equal to 100 mics of fentanyl. We are going up to about 20 milligrams an hour if we need to. We do give a bolus at the start, which is of about 10 milligrams as a push. Dexmedetomidine, now be aware of the bradycardias. What we are seeing very consistently in almost all of our patients is that despite being sick, despite being in respiratory distress, some of them that come to ICU, they are not tachycardic. Their BP would be borderline, they still won't be tachycardic. So if they are already relative brady at about 80 to 100, we do start them on dexmedetomidine, but at a very low dose. So usual starting maybe at 0.7 mic per kg, but we are starting at 0.2 to 0.4. And if that doesn't reduce their heart rate any further, we'll go a bit more higher. Otherwise, we will titrate it to sedation. So these two agents, which is nalbuphine and dexmedetomidine, are our mainstay. And if we need a third agent, it would be midazolam. Rarely we'll need a fourth agent, which would be propofol, but we'll be very wary of it, and we will use it in low doses. Now, depression, it's just a new surrounding for that patient who has never seen you, and they came to the ED, and from ED they have been shifted directly to a place where no family visits are allowed. There is no mobile, there is no contact from the outside. Their only contact is us, who speak to their family and then inform them of what has been said and lay off the messages. They're alone in their room most of the time, and it has taken a toll onto the patients very, very massively. So if they do have a history of depression or they are on any antidepressants, please leave them there, because most of the people would be extubated hopefully in 2 to 3 weeks time, and it should be running at the time. If not, then quetiapine at a low dose, or amitriptyline, or any of the SRIs, SSRIs or SNRIs that you know or you're comfortable with using, please start them. Site review as an inpatient can also be done if there is proper PPEs and the patient is not short of breath enough to talk. Some of the agents, now montelukast has shown a viral protease binding. It does inhibit monocytes and macrophages, and its anti-inflammatory activity. It was used in COVID-1 as well. 60 milligram load leads to rapid rise in the plasma levels, and so we are doing 60 loading and then 10 milligram. We will be starting a trial hopefully soon on it, and once we have gone through our ethics and research review committee, hopefully we will start this here. Ivermectin, 200 mics per kg. Initially we gave it for about 4 doses. There was a shortage in the market, we're not doing that anymore. Vitamin C, after discussing with our heme colleagues and looking at the data with regards to methemoglobinemia, we are giving it about 500 milligrams PD, which is a very low dose as compared to the doses required in methemoglobinemia. But that is something to think of, has got minimal side effects and can be safely given in renal failure as well. But if the GFR is absolutely less than 25, probably omit that. Montelukast has minimal side effects. The only box warning is suicidal ideation or depression, but most of the patients that are being given to it, they are in observation. This slide is just absolutely amazing. This is from EMRAP website. So you see the trend, the oxygen, viremia levels, and an inflammatory response. So the early intervention is the red box, where awake proning is the key, which we are doing as well, and which leads to massive improvement and probably prevent intubation. NIV or CPAP or BiPAP, whatever modality is needed according to patient situation, would prevent deterioration and intubation as well. Now, judicious fluid administration is massively important, but also these patients, if they do go into renal failure, then their mortality massively increases. So beware of that. So do give fluid when it's need to. Heparin or Clexane, we talked about that. Low dose steroid, we talked about that. And avoid intubation in multi-organ failure if you can, which is by giving fluids and appropriate inotropes as needed. Now, delayed are the ones that are presenting late. and intubation is usually required because usually they are in extremis at the time of presentation, and NIV may not be helpful at that time. Hemodialysis may be needed, and we have done it. The filters do clot, so therapeutic anticoagulation along with pre-filtered heparin, and pre-filtered heparin should be given at full dose, which is usually about 900 to 1,000 units an hour pre-filtered. TPA we haven't used. Low dose steroids again, should you need for tocilizumab? Yes, and we are giving it, and I'm all up for it. I think it's excellent drug to our limited experience that we have here. Long-term functional outcomes, we don't know, but probably the time will tell how the COVID pandemic prevails and what are the long-term functional outcomes with these destroyed lungs in these patients. Thank you very much.
Thank you, Dr. Rehan. Our last speaker for the day is Dr. Faisal Sultan. He's the CEO of Shaukat Khanum Hospital. He's an ID consultant at Shaukat Khanum Hospital, and he's also the PM's focal person on COVID-19. The title of his presentation is COVID-19, Surveillance Challenges and Measures Taken by the Government to Control the Disease.
All right, thank you very much. Very briefly, I'll go over some of the actions done at the governmental level to try to contain the spread of coronavirus infections, as well as some other general measures taken beyond sort of the medical or the direct medical or clinical part of the decision making. So first and foremost, one of the most important challenges that existed when this thing started was the lack of testing capability in the country. Since the test that is directly involved is really a polymerase chain reaction, there were not too many labs that were able to do this or that were doing this at the outset. So at the beginning, 4 laboratories across the country were chosen, and the challenge was to be able to ramp this number up so as to reach a point where a test was available in all provinces and in all territories. And not only that it was available, that it was easily done and cheaply done or done freely at governmental cost, so that one got a clear picture of what was going on. So to that end, the National Institutes of Health have actually done a very good job in trying to recruit more and more labs across the private sector, across the public sector, as well as in the non-profit sector to build this capacity up. So where we were at 4 labs only a few weeks ago, we now have nearly 70 laboratories that are doing this test, obviously ranging from very small throughput labs to very high throughput labs. And the current testing ability, the capacity as it stands today, the functional capacity is about 20,000 tests or more per day. So that's been one of the most important and crucial things that were put together by the federal government in cooperation with a lot of local entities as well as with the federal, with the provincial governments. The second thing that was crucially important was the need for coherence. Because of our federal structure and the 18th Amendment, all the provinces, 5 provinces and AJK really function as independent entities as far as health is concerned. They make their own decisions, they have their own policy, and really the data flow was completely broken between the Federation and the provinces. And so to have a coherent response, it was very important to connect these entities together. So a lot of very quick effort was made, and I think almost in record time, the various entities were brought together under one umbrella in what is the NEOC, which is really the polio database. And so because the polio workforce is large and they have a huge reach, they were used to ensure that the laboratory positives were being fed into the system in each province and into their own respective systems. And now the systems talk to the central database on an automated basis, so that allows and enables complete visibility of the positive cases that are coming through. Very quickly, what we realized obviously was that we could not have a reliance just on the testing positives, because our per million population testing would not go up to, say, Korea levels very quickly. And so we needed additional points of information that were crucial in decision making. And that included the number of people who were on, who were admitted for coronavirus infections or COVID. Then the next step, those that were in HDUs or ICUs and required oxygen. So that information had to be fed into the system. And then again, those on ventilators with this disease, and lastly, those that were dying of this disease. So because you cannot have a complete visibility on the lower part of the iceberg, which are the undetected cases, it was very important to at least those to get a handle on those that are hardcore numbers and that really have great impact on how you plan and how you go forth. So that was the additional piece that was put together, and that has actually served very crucially in the decision making, not only to see where the epidemic curve is going, but then to also match it up with hospital availability and capability. So that was the next piece that had to be put together, which was to see what proportion of our hospitals were full and what proportions of ICU beds were full. And so this also required some doing, because at the end of the day, there was no central information which gave this information in a live or real way. So that has been built as well. And now individual hospitals are feeding in their information. And so while the Federation was doing this, the provinces also have taken the responsibility themselves to some extent of this and put together some mechanisms of putting the available information of healthcare capacity in the system. So while doing the assessment of healthcare capacity, one of the other important and crucial bits to address was personal protective equipment. Now, again, while fundamentally this is in the domain of the provinces, but in a crisis like this, all the governments have to and had to pull together. So the estimates of what was required and where it was required had to be made. And again, estimates of use had to be ascertained. And so the National Disaster Management Authority, which has been central in procuring some of the materials for this, came into action. And for most part, they were able to initially import things that required to be distributed, and then of course to distribute them according to where the need was. And this has also been a dynamic process, because obviously at the outset it was where expected need was, but then as time has gone on, we actually have information on where the actual need is. And so I think they have been able to titrate and adjust their distribution accordingly. Now, to give coherence to all this, it was crucial to have some central decision making. And the government formed the NCC, which is the National Coordination Committee, which really is a strategic body, meets once or twice a week. And there the provinces and the AJK government sit in together with the federal government, and really strategic decisions are taken. But the operational ones had to have another forum. And so therefore this NCOC, the National Command Center, was formed, which is really the operational arm of the NCC. There is representation around the table from different provinces, including from health, and I also sit on it to provide input and guidance as far as the epidemic is concerned. Then other entities that have a direct impact on how we respond to this, all the way from the Federal Health Ministry to the provincial chief secretaries, as well as the Prime Minister of AJK, as well as some military organizations that are helping in this response. So all put together, this became the nerve center and the command center for the operational decision making for this thing. Now, this was a very, very crucial step, without which a central coherent response could really not be taken care of. Some other effects of all this have been that when there was a need, for example, for personal protective equipment and ventilators, for example. The Ministry of Science and Technology was able to step in along with Commerce and other entities to make sure that a lot of production started to happen of these things within the country. Hand sanitizers, we went from being in great shortage to having enough now that we can think of exporting to other countries because we produce a lot of ethanol. So that connected various bits together, the need, the demand, the industry, and to sort of make sure that this was there. Similarly, with almost all PPEs, except perhaps the N95, and I think even that is in production now, and the numbers will go up to a point where that hopefully we'll be able to supply all of our needs from within the country. So this has gone from really being nearly zero all the way to not only catering to our needs, but also considering supplying other countries. Similarly, for ventilators, here we are where almost no ventilators were produced in the country of any kind. And we now have had over a dozen or maybe 24 applications for various designs, and some of the designs really are in somewhat advanced stages of their prototypes and approvals. So while that may not immediately impact on the present corona crisis, but hopefully it also helps strengthen our healthcare industry. The other role that the government has had to play and has played is in providing some centrality of guidelines. Now, all the provinces and sometimes even institutions have had their own guidelines to all the way from clinical care to personal protective equipment to infection control and other so-called SOPs and safety measures. But a centralized clearinghouse has been created, and the National Ministry now puts out a bunch of different guidelines to make sure that at least when a province follows these guidelines, they at least are in line with basic best practices, and some reliability could be also placed on that in there. Now, looking a little bit beyond the immediate needs and requirements of PPEs, etc., the government has also required to make decisions on how to lock down, how to unlock, and where to go. So one of the most important strategies put in place was this test, trace, and quarantine. And this was really based on the ability of finding co-located persons who then are really the contacts for the index person to enable a more targeted and smart approach to doing tests as opposed to sort of a blunderbuss across the board testing. So this TTQ really is in place and utilizes a number of different platforms and technologies. And then it is also had to be built. Somebody used this term, building a plane while you're flying it, and it has felt sometimes exactly like it, to really build this TTQ mechanism and process while in the thick of it. So this has helped us to now inform the provinces on where to test and exactly who to test. Now, they were doing their own on the field contact tracing of a more conventional nature, but this is added to that capability. And lastly, the thing to come, which is in process as we speak, is the automatic generation of hotspots. Now that the restrictions have been eased up and we can see that how we sometimes exceed what has been allowed to us. But nevertheless, these coming days will require a very agile capability to lock down specific areas or to close down specific entities to ensure that we continue business without shutting down the entire country. And so there again, we're using very advanced technology to try to figure out how to define what a hotspot is and various gradations of it, and how to actually react to it, and how to inform the provinces to do this on an automated basis. On a manual basis, obviously, this is going on as we speak in any case. So these are some of the sort of nuts and bolts of some of the responses that the government has done to try to control the spread. Obviously, I have not talked about domains that are not fundamentally medical or epidemiologic in nature, but obviously that discussion relates to so many other things that the government has done, but which have been informed by the data and science that has been coming out. And lastly, the data and science has been done in a number of different ways, from conventional epidemiology to using artificial intelligence and data science to do some predictions. So hopefully this gives you a quick overview of what the governmental response has been so far. Thank you very much.
That was a great talk, Dr. Faisal. Thank you for bringing us up to speed with the developments at the national level. We will now be answering some questions. So the first question that we received is, why has hydroxychloroquine been recommended in the national treatment guidelines? So since I covered treatment, I will go over the answer for this. So it was recommended initially, and as I mentioned in my presentation, that the initial data and most of the data was on hydroxychloroquine. The drug had shown in vitro effectiveness for treating COVID-19. There were small studies that showed efficacy as far as treatment is concerned, but they were limited in terms of the fact that they only recruited patients who were either mildly or moderately ill. However, in the light of recent evidence, I mentioned 2 observational studies that came out last week that compared hydroxychloroquine with no treatment at all, and they saw that there was neither any benefit nor any harm of giving it. So there might be modest, clinical effect, if at all, with hydroxychloroquine, it seems at this point, and it's best to use it in the setting of a clinical trial. Now, secondly, we were asked, interferon beta, lopinavir, ritonavir, and ribavirin have been hailed as more promising compared to remdesivir. So what are our comments? So again, since I went over the treatment, I will answer this question as well. So, this basically refers to a trial that came out in Lancet earlier this week. This trial was conducted on mildly ill patients, so that's the important thing to note. And they compared the combination therapy of interferon beta, lopinavir, ritonavir, and ribavirin with lopinavir, ritonavir. So it's not that they had compared with remdesivir or with standard of care. So again, looked at mildly ill patients, and as we know, 80% of patients who get COVID-19 are mildly ill and they recover on their own. So we don't know what this drug did, or if it did anything at all for those patients. They may have recovered even if they hadn't been treated. So again, this should be studied further in the setting of a clinical trial where you're actually comparing it with either standard of care or with remdesivir or other treatment modalities. And in addition, we really want to see, we really want to explore what therapies we can use to treat patients who are critically or severely ill, because as we know, moderately and mildly ill patients recover on their own. So these were the problems with this study, which is why it's not promising. It cannot be touted as promising or more promising than remdesivir at this point. So the third question that we have received is, for those who are positive with COVID-19 and are asymptomatic, do they really need to repeat PCR, or they don't need to repeat PCR? So, okay, so I think this also brings or highlights how long people should be in isolation and when to discontinue isolation and all of that. So for right now, the recommendation has been extended from 7 days to 10 days of isolation. And at that point, if a COVID positive patient has been afebrile for at least 3 days, with other symptoms improving, for example, if they had a sore throat, cough, myalgias, etc., if they are improving and they've been afebrile for 3 days, then at this point there are 2 recommendations. Number 1 is that you just discontinue their isolation, and number 2 is that you test them, you repeat a PCR, followed by, and if that's negative, you follow that with another PCR in 24 hours. And if both of those are negative, then you discontinue isolation. Now, the testing strategy is touted as the preferred strategy, and the non-testing strategy is touted as a reasonable or acceptable alternative. So at this point, it depends on an institution's testing capacity. Number 2 is centers that are specialized and you can't let go of your healthcare workers have been using this policy even for healthcare workers. We have recently moved to this strategy as well. And I want to add that it's not just based on the fact that you may have a shortage of healthcare workers or something to that effect, but also the fact that there has been one study at least to look at how long there's live virus present in a person's respiratory system. That's the most important thing to determine at this point. When you're culturing someone, you're actually recovering a live virus, whereas if you're performing PCR, you may be picking up dead virus. And the infectivity for SARS-CoV-2 is really highest within the first 5 to 6 days. It wanes after that. So, it has to be a risk-benefit ratio. I mean, based on that, and what your circumstances are, you can pick which strategy you want to adopt for your healthcare system. So, those are the questions. Dr. Fester, are you still there? Okay, thank you everyone. Thank you for joining. We will inshallah hope to plan another webinar soon. Thank you. Allah Hafiz.